Okay. Well, again, good afternoon or good morning, everyone. Thank you for joining today's session. My name is Casey, and on behalf of the PRRP Exchange team, we are excited to have you join today's session and take part in a discussion around ED recognition programs. Before we get started with today's session, we would like to acknowledge that the EMSC Innovation and Improvement Center is funded through a cooperative agreement with the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. As a cooperative agreement with a federal agency, the EIC must adhere to executive orders and related federal guidance. Currently, EIC-funded staff are unable to engage in activities or discussions on topics that are limited by executive orders. We appreciate your understanding and ask that all meeting attendees refrain from discussing any topics of concern. Additionally, the contents of today's presentation are those of the authors and do not necessarily represent the official views nor an endorsement by HRSA, HHS, or the U.S. government. And here we have the goals for participating in the PRRP exchange. These come from your survey responses. And the goals are to collaborate and hear from others implementing recognition programs, to collect resources to support recognition programs, and to identify and address barriers related to recognition programs. So to help us accomplish those, during today's session, we ask that you do turn on your cameras if you're able to, and share your experiences and ask questions of one another. So today we will be discussing application and verification related to ED recognition programs. So for reference, during today's conversation, we have the Pediatric Readiness Recognition Program Implementation Suggestions document. This document is only possible because the contributions made by you all throughout the Pediatric Readiness Recognition Program's collaborative. The document is not a mandatory process for adoption, but a resource which can be used as a starting point to adopt and utilize when creating and revising your recognition program. So I can go ahead and pull that up for us today. So when navigating the EMSC website, if you go to Engage with EMSC and visit the Recognition Programs page, travel in the menu to Resources, you'll find the Implementation Suggestions document here. Open that up here. As a recap, there is an overview of the phases of development. See that summary in a more of a visual format. And then the process of developing an application and verification process are outlined here as a series of steps, which you could adapt for your program. So those resources can again be found under the resource page of the Pediatric Readiness Recognition Programs Collaborative. While I have this up, actually, I do want to also share, if you go over to the EMSC programs and state partnership programs, during last month's session, there was a lot of resources that were being shared, and reached out to those who shared the resources, and we've added them to the state-created library. So you can, if you have other resources that you would like to share with the group related to recognition program, you can either share them with me or use the webpage to email us that resource, and we can get it added here so you can all reference them. You're able to search, I don't know if Amy Myers is on, but I believe if I just search recognition program, those resources should come up. You know they're in there. Not certain on the search features, but we can figure that out together at another time. But if you have resources you would like to share with us, go ahead and email them to me or through the webpage, and we'll get them added to this table for everyone to reference. Just wanted to share those few things with you. Right. So That being said, I do want to go ahead and have our time dedicated to the discussion. And we have Michelle on today to help facilitate the call. So I thought we'd go ahead and get started with the application process.
When creating an application form, let us know, how do you guys share these forms and where are they posted? Any of you guys can come off mute and share where you guys have how do you share them, or if they're posted, or do they have to send you an email to get the forms? And then how do you track your responses? Okay, Emily, thank you. Hers are posted. They aren't, mine are posted anywhere yet. Okay. Do others have anybody have them posted? We only have pre-hospital programs from Rachel Ford, accessible through Oregon EMSC. Kelly in Illinois, her application forms packets are located on the EMSC website, on the IDPH website. Do you guys find challenges having them posted versus being emailed?
I think it's a benefit to having them posted on the website, as individuals are able to access them. The one challenge we have is due to some of the advanced formatting, because all of our applications are a fillable format, but the formatting and security measures that are built into them, it really inhibits that direct download and open. You have to, download it and then go in and then right click and open with Adobe. So it's just a few extra steps, and it's trying to keep people up to date on that little work through. Because more often than not, it'll be like, hey, I can't get the forms to download. Can you email me them? So just working them through those processes. But I think having them readily accessible gives individuals that might are at a facility that aren't yet participating, or they know that their renewal cycle is coming up. They have a chance to look at it and kind of review and be like, oh yeah, this was last year or our last cycle stuff. Here's what we're looking at for this next cycle.
Yeah, so it's easy for them to look for updated information and see what they need to have to fill out the application too. How about others? So I see some of the pre-hospitals have online application links. Emily, I'm trying to decide where the recognition program website should be located.
I have a question.
Yeah, go ahead, Michael.
So some of you have already had the opportunity to bear my questions from another group, but being new to this process, I'm not even sure that we've got a hospital versus pre-hospital recognition program in place yet, or even started that process. So actually, I'm meeting with my EMS folks next week. How do you market this? How do you market for hospitals who would want to take the time and effort to be recognized as pediatric ready? I mean, is this part of an ongoing visit? This comes from the committee, or how does this get marketed so that the program is successful and actually you're not spinning your wheels?
So how have others done that? I'm sure that's a big challenge for everybody. How do you market it? How does everybody know it's there? I know in Ohio, we recently, our Ohio Department of Health and the EMS section sent out emails, because this is a new program for Ohio. and they went through like the emergency management team first to see who might be interested, which I think it's a great way to reach out to people, but I don't think the emergency managers know if their ED wants to be recognized, but I think it's they had that contact list, so that's where they started. And it trickled down to, I think, the ED managers. How about others? The EMS program report, bi-monthly PEDS champion and PEC newsletters, which everybody may not have. Do you guys have newsletters, some of you, that go out to different sites, even your EMS, that they could share?
This is Cindy, and in response to Mike's question, not the newsletter, because we have one agency newsletter, and that is how the governor wants it. So I have a page in that newsletter. But in response to Mike's question, we actually spent 2 years building what the federal government calls PACs. We call them pediatric champions. And it wasn't until we had a nurse champion in almost every ED that we then actually launched the program. We had the criteria, discussed it with physician networks, ACEP, ENA, AAP, but once we had the champions and had met with them for a full year, including an in-person meeting in the nursing pediatric champion role, then while it is their hospital CEO that must ask for the application to start, and that is how all hospital relationships with our state agency are done. So I was asked to follow that. Everything that goes to them also goes out to the pediatric nurse champions. The physician champions are now getting on board. We're at more than 50% as of some updates that we got this week. But that's because they can't apply until they have a physician champion. So we sort of built that in. But now the job starts. Actually, it started in June. They've got the ability, but walking them through and getting people to apply will probably be another 2-year process.
Yeah.
And that's optimistic. It has to be a 4-year process because I retire after that.
No, that's great. That's a great idea, is using your pediatric champions to help them get buy-in from the hospitals. Because they have to do a lot of the work for that as well. Emily, they show up at regional meetings. What type of regional meetings do you show up at, Emily? Are they for EMS, hospitals, or PECs?
No,
willing to
usually
share?
like emergency department leaders and emergency preparedness leaders and things like that. Or if they're having summits on certain things where they're going to gather a bunch of people, then I try and say, hey, have you heard about these programs, and talk about it and give them materials.
That's great. Great idea. Arizona presents their program and shares the application during the trauma program manager workshops. Okay, that's awesome. How do you guys track your responses? Like of people in process versus those who have applied?
Michelle, I'll tell you where I am. We have created an Excel spreadsheet that we will track it. I'm stealing it from Mary Ellen, who is the lead for our nurse coordinators. She already has an Excel spreadsheet, so I took the basis of that. But right now, I'm tracking it by folders on my desk because I only have 3 in process. It will,
good, though.
with a denominator of 49, we will need an Excel spreadsheet, and that's why I'm drafting one for Mary Ellen to critique, because she's our IT specialist. But what I've heard from other folks is sort of an Excel spreadsheet or something that does that, where you can say, when did you get a letter? When did they start the application? We're asking within our intake form, do they anticipate submitting within 2 months, 4 months, or 6 months? It's a voluntary process, so I don't have a mandatory clock for all other hospital
Yeah.
processes. It is in code what that mandatory clock of 3 months, 45 days, and 30 days is. We are not using that timetable. And there was a big sigh of relief that we were not, because this is a new program. But if this is codified, there will then be a very specific timeline the hospitals must adhere to.
Well, thank you for sharing. How about others? I see Caitlin, they're using Qualtrics so they can track and download responses into an Excel spreadsheet. Anybody else doing anything different? Are you tracking? Or you wait to just get all the information and then go from there? And then if we don't have anybody else sharing that, what is included in the application? Are the sites and agencies required to upload documents as part of the application? Or is it a simple fill in the box? Or do you want the policies and stuff beforehand?
I'll jump in. So for Illinois, within our application, they have a checklist which guides them on what all needs to be completed or filled in and submitted. And that includes some specific documents that have been created, such as their request for recognition or re-recognition, their credentialing forms for provider levels, that identifies who the provider is, their full-time, part-time status, their hire date, like for physicians, what board they have, advanced practice providers, what that nursing specialty is, like pediatric critical care nurse practitioner or pediatric emergency nurse practitioner. It tracks certifications such as PALS, ENPC, APLS, and then there's also a column that tracks their continuing education hours, because with our program, different provider levels, whether you're ED or inpatient, are required to meet specific continuing education hour numbers. So all of that's tracked, and there's a form for your physicians, for APPs, and then for nursing. We also have a checklist that is dedicated to disaster preparedness. So that has to be filled out. And then there are different specific policies that are asked for, that incorporates the administrative code verbiage, what they need to be doing as requirements, and shows that they are, written into their policies. So it's a combination of forms and supporting documentation, be it in the means of policies. And then we do even more looking when we're there in person to validate the certifications and the education hours, meeting minutes to see how pediatrics is incorporated and that it's a standing agenda item, those kind of components. We make sure that they're not submitting things that could be, HIPAA or PHI or anything like that.
Yeah. No, thank you for sharing, Kelly. Anybody else have a process for that? I know Cynthia, for the physicians, only requiring the weight and documentation and weight and kilo policy, and process be submitted in advance, and then they ask for everything else to be there when they come out. The smart sheet requires response for policies and procedures for the ED or hospital, whether they're ED or hospital-wide. How about others? Anybody else have a good process for that? Or a process they want to share? So if the application is reviewed before a verification visit, is the application reviewed and approved before you go schedule the visits?
Like, Dwayne has his hand raised.
Oh, go ahead, Dwayne.
So I'm just thinking that whatever we do, and I'm approaching that stage in the ED program of needing to develop this. It's got to be the least amount of effort on my end, simply because of numbers, and the most effort on the participating facilities end, because they're in control and they have firsthand knowledge of all this information. And whether they share it at a one time when they're applying or renewing, or whether it's on a shared portal, I have mixed opinion about that. I don't think we have the funding to be able to support a portal that they could go in like EMS agencies go in for their licensure and update. But I'd love to mirror that for both the EMS and ED recognition programs, because it allows access from all sides that are authorized at any time to update information. I'd love to hear. I know I've seen the Smart Sheets option. I think that's a great option, but I'm not as familiar with it. But anything that's helpful that reduces the amount of workload on our end as a program, and keeps the responsibility at the participating facility or agencies level, I think is important.
Is anybody using a certain form or smart sheet or anything for this? Rachel's smart sheet's pretty easy to learn. How about others? What are you guys using? Anything, or just collecting documents?
If anything, that gives you the ability for the person who submitted the documents to like go in and revise or to provide additional information. Anyone using a tool like that?
They use learning management. Okay. That's from Samantha. There's this, most of you guys still using like email documents?
We have a separate, if it had any PII that our state provides where they can drop something, but I think the bigger question is who's reviewing all of this instead of like what method you're using, because it could be as simple as email. You could have them mail it to you, because I mean the volume, it sounds like most states are doing isn't, except for Illinois and a few states, isn't such that someone could just email you these. The workload is actually reviewing it.
Caitlin said Qualtrics has worked great for us. You can make it required for the application to answer each question. Oh, that would be nice. And easily upload a number of attachments. Good ideas. Good thoughts about though who's going, like how much you're getting in and who's going to review those details. And that's, I think, going into even our next question about like, is the application reviewed and approved before your visit is scheduled? So do you review some of your documents before you go out and before you schedule that? Or do you wait to get there and then find out that they have everything or they may not have everything?
We request definitely the policies and procedures, anything we had a question on, because of the amount of time it takes to review that.
That may give them opportunity to be able to provide you that information before the verification visit is scheduled.
Yep, right.
Are sites given feedback on the application? Caitlin, request documents in advance.
I think the
makes
feedback
sense.
we give is the information they submitted clear and satisfactory to meeting the requirements. I think that's as far as I'm willing to go in assessing what they're submitting in application.
Okay. Thank you, Dwayne. Okay. Request all documents in advance. Do you guys have any resources to share? I know we talked about Qualtrics for some people. Kelly, Illinois staff is the sole initial reviewer. And feedback's given good. That goes back to having all the information before you go out to the site. Because they may not be meeting criteria and need to update some things before you go out. Anybody have any resources that they would like to share on applications or their step-by-step process? Okay. We want to go to the next slide, Casey. Okay, when looking at verification, let us know who attends the verification visits. The EMSC program representative and site agency representative. Who else do you require to be there? Who do you think should be there? Can you even put it in the chat, guys? EMSC medical director, program manager, ER nurse manager, ER physician lead, whoever else they want. Probably their PEC too, if they have a PEC.
In our experiences, we're just like the ER nurse managers and our ER physician leads are usually our PECs. So
Okay, great. Anybody else? Ask for anybody else to be there for your verification visit.
Are you talking about who does the site visit or who do we ask the hospitals to have present?
I think who do you ask the hospitals to be present? Casey can correct me if I'm wrong.
However you guys like to discuss it today.
Yeah.
Go both ways, or
Yeah.
there's an angle you want to discuss?
Like I say, I mean, we include in all of our guidelines and communication out to the hospitals, different people that are recommended to be there, like the PEC, which we call in Illinois, the Pediatric Quality Coordinator and Pediatric Physician Champion. So those individuals, their EMS coordinator, their hospital preparedness manager or disaster coordinator, ED leadership, hospital admin, if a hospital quality representative or designee, those different types of roles. If it's a hospital that uses APPs, having their ED medical director there, in addition to the physician champion, and then an APP that can speak to the APP role, just really those individuals that are touching the whole care of a pediatric patient. On our survey team side, it's one of us from the EMSC program. We typically end up with another IDPH staff member there as well. We have 11 EMS regions in Illinois, and each of those regions have a EMS regional coordinator. And that individual usually attends as well. And then we have an emergency department physician surveyor, an emergency department nurse surveyor, and then a disaster surveyor. So that's kind of our basic team. And then if we're going to a tertiary care center that has a PICU, a PEDS unit, and those sort of specialty care areas as well, then we add a pediatric physician intensivist, and a pediatric intensive care unit nurse as well. So we're able to kind of have subject matter expertise for all those different areas.
That's great. How about others? MD, it depends on the level of pediatric readiness. We have 3. Okay. Great. And I know Rachel Ford put some information about her recognition program LinkedIn there. Is your intensivist, Kelly, used for if you're doing more hospital or just ED?
No, the pediatric intensivist is only at a pediatric tertiary care center. So we have the 3 levels: the pediatric critical care center, which you have to have a PICU, a PEDS unit, and transport, like either your own transport team or access to a transport team, as well as different pediatric specialty services. But the pediatric intensivist and the pediatric ICU nurse would only be involved on those surveys. For our emergency department focused only, we've got the emergency department approved for pediatrics, and then a standby emergency department approved for pediatrics. Those are just an ED physician, an ED nurse, and then our state representatives as EMSC program, IDPH, the EMS regional coordinator, and then the disaster coordinator.
Okay, great. Thank you for clarifying that. Kelly, in addition, everything else listed, we asked for pre-hospital service manager to attend. Do they attend just the pre-hospital site surveys, or do they also attend the hospital surveys? Kelly?
We don't do an in-person visit for pre-hospital. So that's just, so yeah, this is just for hospital.
Okay.
Oftentimes, like a service manager can't make it. Obviously, they have a 24/7 schedule, so just someone representing them.
Okay, great. Thank you. Anybody else on who attends? I think we can move to, what are your recommendations to conduct an in-person versus virtual visits? And I think so this is some of where your volume and funding comes in as well. And now Michael mentioned the cost of site surveys.
I did. I know that Dwayne mentioned the cost prohibitive,
Yeah.
particularly for the pre-hospital side. But, in other areas where site surveys are done, those folks get paid or they get a stipend. And I just didn't know where that money came from. And then I'll ask the other part of the question is if a facility is going to pay a fee for a site visit so they can become pediatric ready recognized, what happens if they don't? What happens with that money? I'm just asking the question because I don't know.
Good question.
So this is our consideration. We haven't implemented it, and I've taken a couple things from other programs. We're considering a ED recognition program fee for new applications to assist with covering the cost with an in-person site visit, because our thought process is new applications have an in-person site visit. It's an engagement to get to know, it's to put eyes on, it's to just support the process. We did incorporate new applications in the EMS program to have in-person site visits with the program that just rolled out July 1st. There was no charge for EMS agencies. And that consideration came with a lot of conversation. But I think offsetting costs because of travel, because of number, because of the individuals who may attend, who are volunteering their time, we've got to at least pay them for their travel, if there's overnight stay and stuff like that, that it becomes burdensome if we don't consider that in the program development. We're not considering renewals or upgrades in recognition level to be in person, so we can reduce costs, be more efficient with time of anyone who's going to be part of the consideration and the visit itself, and just make it more efficient program.
Thank you. Illinois does not have fees for facility participation and facility recognition. They get an honorarium and travel reimbursement via grant funds, which is awesome. I know Ohio is just starting theirs and they are charging a fee. Oh, there you go, Kyle. Yeah, to help with the honorarium. To help pay for the surveyors.
And I can appreciate the, like Rachel from Oregon said, it would be a barrier to participation. The bottom line is participation more important than the quality of the program? Are we looking to get numbers, or are we looking to have a quality program that may have less participation? And hopefully participation will draw out other facilities to be more interested in a competitive edge, or just in the knowledge that someone else is doing it. Sounds like a good idea. We're going to move forward. I know when Wyoming presented a few years back, they addressed their critical access hospitals, and the community hospitals in the state got jealous, and they got engaged because of the competitive nature of the activity.
You think if they're charged a fee, it's more of they have more buy-in?
I think if they're willing to pay a fee, they have more buy-in, and there'll be more success versus, and I take this from feedback from my EMS program, the legitimacy of my prior EMS program came under question because of the accountability of the agencies. It was a one and done, and it was a lot of attestation and yeah, we promised to do this, versus verifiable information and in-person or direct verification of their activities are meeting the requirements.
Thank you for sharing. Okay, how are the results of the verification visit communicated to the site or agency? Do you give them like at the end of the survey, if you're doing it in person, give them any idea, inclination if they passed, if they didn't, or do they have to wait to get and identify what they need to work on? And then along with that, who decides really if the site or agency sufficiently met the verification requirements? I think those go hand in hand.
In Rhode Island, we sit together. It's like the medical, so we have two medical directors for our EMS for Children program, and then Caitlin, my program manager, and myself, we all sit down and have kind of a powwow about what we think could use improvements, because we require as part of our program that they submit like a plan for improvement, or like an action plan, and we just make sure that everything that they are submitting is meeting like our expectations. So I guess there's a little bit of subjectiveness to this, a little bit in terms of what we think is needed, but so far the hospitals that we've done are, that we've visited, they've been pretty great about working with us, and they haven't had any issues with putting together an action plan, and they've really been enthusiastic about getting recognized. So it's been pretty easy. But again, I feel like I'm in a completely different boat than half of the people, on this call, because I have 11 hospitals in my state that would, potentially qualify for a program. So it's a little bit different. I can drive in one day and visit all of these programs if I want, all these hospitals if I want to. So yeah.
No, thank you for sharing. How about others? Kelly. We do a closing session, shares kudos and needs, and they receive a letter that spells out everything. Okay. Final determination. Okay. Thank you. How about others who have started and do site verifications?
We do something similar to Illinois. We do, it's not really an exit interview, but at the closing, but we've already reviewed their checklists, policies, procedures, etc. before we came on site. So we already have a pretty good idea that they're going to pass. Again, it's not cost effective to go out to hospital if they're not going to. And then we send them a report within 30 days. But we let them know in person.
That's great. Thank you. Yeah, I think when you think about that, it is very costly if you have to go out multiple times. Making sure they have everything that you need up front is important.
Yeah. One of the things we don't typically do a lot of like quote unquote revisits, but we will occasionally do a revisit, and sometimes that can be done virtually. It depends on where the major gap or deficit was. So as I mentioned, and Kelly also mentioned that she does in their state as well, but they get that closing session, and the hospitals are, taking notes and, of what items are needed or things like that. And we give them that opportunity too, while they're waiting for their post-survey letter. If there's something they feel that, they can go ahead and submit prior to getting their letter, they can do that. Sometimes it's as simple as, they needed to show that they got a supply in that was expired or they didn't actually have or something. So maybe they're just submitting that purchase order or a picture that they actually have it now. Or maybe they had a policy that was in draft form when we were there because it was going through its routine updates. So they just need to submit the finalized copy. So things like that can be accomplished even prior to getting their post-survey letter. And then they get their letter, they've got that time frame with which to address things. However, on rare occasions, there can be times where a hospital just has such a significant gap. A lot of times it's due to changeover and loss of that continuity of operations. And so instead of maybe doing an improvement plan, just like say, hey, this was our identified need, this is how we're going to get back to where we need to be. It may be a corrective plan of action, and that then requires a revisit of some sort. And like I said, we're able to do that virtually sometimes. And then they just provide quarterly updates to ensure that they are meeting what they said they're going to be doing in their corrective plan of action and staying on track with everything. And then they're able to get there, yes, you're re-recognized and you're good to go.
Great, thank you. So Florida, we have a discussion. Looks like most people have a discussion and a closing session, letting them know what their strengths and weaknesses were, where they have maybe some opportunities. So Kyle has a question. Kyle, you want to ask your question?
Yeah, so I'm with the Ohio EMSC. I'm new to the program. We have not completed any official site visits yet. We're preparing to, though. With that, we're asking ourselves kind of, is there, or I guess, whether or not there's any sort of grading methods or systems that other states are out there currently using as far as like different criteria being weighted more or less than the other? And then with that, is it a straight pass or fail? Is there like a minimum percentage of criteria that the facility has to meet in order to receive that recognition? I guess we're just kind of asking how exactly that looks compared to other states and how we'll approach it after a visit is complete and when we do our final review and determining whether or not a facility receives their recognition.
How do others do it? Is it all or none? You have everything or you don't? So Kelly is meet or don't meet. Okay. So every criteria on your or for your recognition program has to be met for you to pass. Okay. Looks like another Caitlin as well. Met or not met, pending. Okay. And does anybody else have any resources to share that they want to share or can share? Okay, I think we have one more slide. Is that right, Casey?
Yeah.
So for those who have created their re-verification programs, how frequently do you do that, and how do you address changing recognition requirements? I think some people said 3 years. I think I saw that earlier. So how often do they have to be re-verified? 3 years. 3 years.
Michelle, this is Cindy from Maryland. Our plan is 3 years. We have a 50-year-old history in this state of doing things every 5 years that we inherited from people who are no longer with us, and we are trying to get rid of that.
Okay.
Because all other national recognitions are being done every 3 years. So EMSC has been put out as the first to do it every 3 years. So I think there's a black jacket coming for me. But the plan is to do 3 years and then move all of the other designation processes from emergency department base stations through all the specialties to 3 years over time.
Okay.
I
wish
think
you
all
luck,
of us
right?
are holding our breath because across the nation, because the newest version of the joint policy statement on pediatric readiness in emergency departments is due out this fall or winter.
Yes.
And then we'll all have to crosswalk what we've said to that. Our plan in Maryland is not to change for the first 3 years, but there may be items within that new policy statement and technical report that would be FYI recommendations to a hospital.
Okay.
Midstream, we're not going to change the rules.
Yeah.
At the end of a 3-year cycle, we may find things that were in the standards the national standards that we looked at and referenced are gone or are no longer relevant with technology.
No, that makes sense. You're not going to take something away that they met criteria at one point. And it looks like most people are 2 to 3 years. We have a 4-year, but yeah, we're all around the same time frames. Wondering how our ED recognition differs from ACEP's recognition.
Is Kate still on the phone? Because she's a much stronger answer to the ACEP accreditation than I will. But if she's not, I'll take a stab at it.
I know she was driving.
Yep, she had to step into her other meeting.
Okay.
Okay. Again, this is I don't know if it's high level or low level, but this is just a real brief summary of what we've learned from the COPEM committee of the Academy of Pediatrics, or the Committee on Pediatric Emergency Medicine. We have talked over the last 18 months at least 3 times with ACEP liaisons and representatives. The ACEP recognition, and they have 2 types. They have one that is geriatric and totally separate. It is a verification. There are levels of it, and the hospital or hospital systems pay for it, and they go in and very specifically look at geriatric issues within an emergency department. They have newly released about 2 years ago a 3-level verification process that is heavily weighted towards physician training, physician credentialing, physician staffing, but does include other components. Within that, they have added a requirement that the hospitals participate in pediatric readiness assessment. There is no score they have to have. There are no details. They just wanted to include and support the pediatric readiness. It does now mean that a given emergency department is going to work with the state pediatric readiness program, with the National College of Surgeons that has a number system, with the recognition typically at the state level of a reversed number system if their hospital has a nursery or newly born care, and now a platinum, gold, silver. I don't have the website up, but I think it's platinum, gold, silver recognition from ACEP. Obviously, the ACEP is a voluntary process. It is an expensive process, but they were very clear this is not to compete with the pediatric readiness recognition programs at the state level, but they did add pediatric readiness, just as the College of Surgeons in their most recent grade book added a requirement that the emergency department and the hospital has looked at their pediatric readiness. And
Thank
Kate
you.
knows a lot more than I do.
Yes. And Robin put a link in as well. So thank you very much, Cynthia. That was a lot of knowledge.
I will say they're changing the name from EDAP just because of the tie-in to pediatric readiness. And it's going to be EDAC. So ED accreditation is the new, so EDAP is going to be going away when they formally launch it.
Oh, Robin, that is great news.
Right?
Thank you.
Yeah.
Yes.
Yes. Agreed.
That took a very long 2 lunches in Chicago to figure out.
Yep.
Okay, everybody. I think we are close to time. Do we have anything else to cover here, Casey? Just our schedule. I'll let you
update.
take it.
Yep. So next month, we'll be hearing updates from state partnership program managers on August 21st. If you are planning on sharing an update, if you could please email it to me by August 20th. And get it all put together. And then we'll be hosting additional focus discussions for ED and pre-hospital in October and September. While you're still on the call with us, we would love to hear from you what topics you would like to have for those sessions in October and September. So if you wouldn't mind putting your thoughts on what we should discuss next time in the chat, we'll take those into consideration and share with you what topics we'll be addressing based on your feedback. So go ahead and take a minute if you can and share your ideas. And then we look forward to seeing you in August.
Thank you guys all for participating and sharing.
Thank you.
But give us ideas to topics.
What would you like to discuss during our next focus session in October and September?
guys. Those of you left have ideas. Give us topics or email Casey.
Great.
Michelle, this is Cindy. My pre-hospital EMS champion coordinator is actually clinically working on the floor today. I
Okay.
will ask her and have her send you all an email.
That's awesome. Thank you.
Sure.
Okay, everybody have a great day.